So, شكرا جزيلا لكم جميعا. معلومات قيمة جدا، محاضرة رائعة. في أسئلة من زملائنا. نعتذر من الدكتورة هالة ما قدرتش تحصل فرصة أن هي تغطي كل
السلام عليكم.
أهلين بك دكتورة. نعتذر أنك أنت ما قدرتيش، لكن عندي سؤال أو اثنين من الحضور يتعلقوا بالموضوع اللي أنا أعتقد أنك أنت كنت حتغطيه. فيه واحد من زملائك بيسأل: هل سي تي سكان مطلوب لكل المرضى أم لا؟ دكتورة هالة لو ممكن تجاوبي.
unmute.
Hello.
تفضلي دكتورة، أنت تو سامعينك، تفضلي.
Okay, CT scan cannot be used as screening test. It is the first thing, but sure, it's not an option always. Sometimes the patient has a high score, according what Dr. Ala explained at her presentation. Sometimes we don't need to proceed to CT scan. But it's highly sensitive, but it's not specific, because there is overlapping between COVID-19 findings and other diseases. But when we put the patient at that score, we have talked about with Dr. Ala, we can decide if we need to do the CT scan or not. But the thing I need to tell to all doctors, it's not a method of screening, because many doctors here in Libya think about to use the CT scan as screening test.
Yes, I think this is a very important point. Some might have heard what the Chinese were doing. With the Chinese model only worked in China. But if I can ask, if you don't mind, Dr. Hisham and Dr. Ala to, these are questions that are coming through the Q&A again and again. Do you even need to get as far as a CT scan if someone has respiratory symptoms in these days? Dr. Hisham, do you want to comment about that? If someone has symptoms suggested, do you even have to admit them in the CT scan? Does everyone need to have that admission?
Right. أنصر متاعي علي أعتقد أني حنحاول أنصر بناء على what's happening in Libya أكثر من هنا what's happening in papers. Okay.
Sure.
طبعا أنا الاتندنس الآن أعتقد الاتنديز أعتقد كلهم من ليبيا. المشكلة طبعا في ليبيا الحاصل الآن إن في a lot of patients they are coming with the chest symptoms, right? And I can see they're coming in different places. طبعا احنا ما زال ما حددناش المكان اللي هو المفروض ان المرضى كلهم يمشوا لهم. يعني مثلا الان في محاولات ان ينظموا اتجاه المرضى الى زاويه الدهماني، مجمع زاويه الدهماني اللي من مجمع زاويه الدهماني المفروض انه يمشي لاماكن اللي هم العزل. لكن ما زال المرضى ممكن ينتهوا في مستشفى طرابلس مركزي، ممكن ينتهوا في الخضراء، ممكن ينتهوا في التي ام سي. وطبعا نتيجه ان لما يجي المريض بchest symptoms و there are many patients with the chest symptoms والchest symptoms طبعا do varies. يعني طبعا زي ما قلت لك الناس ما زال ما عندهمش وعي شنو نوع chest symptoms اللي هو المفروض يتجه بها الى المستشفى وشنو هي chest symptoms اللي ممكن يضل فيها في البيت. يعني لو ضل ان الانسان عنده شويه حراره وكحه بسيطه، يعني في الايام الاولى زي ما قلنا احنا نحاول انه يضل في البيت ما يمشيش لاي مكان، لان هذه الاعراض اللي هي الاوليه نتاع الفيروس اللي هي معظم الناس ممكن ان هم في النهايه بيبروا منها ويخفوا ما يحتاجوش اي تدخل زي ما يقولوا طبي. لكن اذا كان الامور اصبحت في اكثر من هيك واصبح المريض يحس بروحه من الدهشه ويحس انه هو في ضيق في التنفس، هذيك الوقت اللي هو المفروض انه هو ممكن يتجه او ياخذ استشاره طبيه ويتجه طبعا حتى البي سي ار في ليبيا اصبح البين ان البي سي
للاسف الصوت متقطع من عند دكتور هشام.
يدير له السي تي سكان، يعني باين ان السي تي سكان ولا متوفر كثير، واصبح كانه هو الدايجنوستيك، واصبح كانه هو الفاكتورز، بحكم ان البي سي ار مش متوفر كثير، وان النتائج بتاع البي سي ار الناس يتكلموا عليها ممكن نتيجه مشكله الاخذ العينات. لكن البي سي ار المفروض ان ما نستخدموش الا باضافه الى بجانب اعراض ثانيه. لو كان المريض طول جاته باعراض ودرت له تشست اكس راي، لقيت في التشست اكس راي سم انفلتريشن، ما يحتاج انك انت تدي لي سي تي سكان، لان في الوقت الحالي في وقت الوباء اي مريض جاي بتشست سيمبتومز مع بايلاترال انفلتريشن مثلا او تغيرات في التشست اكس راي، انت المفروض تتعامل معاه ككوفيد، من حيث انك انت تحمي نفسك وتحمي زي ما قلنا احنا الان اي مريض يجيك عن طريق الاسعاف تتعامل معك مع كوفيد، ما عادش تعرف شيء ثاني، ما تفهمش الا ان هو المريض هذا جاي كوفيد، تندل له تشست اكس راي، وبعدين ممكن اذا كان هي الاكس راي مش واضحه ممكن يتجه للسي تي سكان. لكن السي تي سكان از وات يقول سكريننج، وانا الان عرفت ان في حاله حتى تشايلد داروا له سكريننج ما عندهاش اي سيمبتومز، رفعوه داروا بيه السي تي سكان. فيصبح السي تي سكان اولا بتعرض راديشن زايد، يصبح مكان السي تي سكان فوكس اوف انفكشن لو كان عندنا مرضى، لانه حيصبح فيه مش تنظيف كثير. فاعتقد ان اللي بيسهل الامور هذه في ليبيا ان نحطوا شيء بسيط اللي هو شنو الحالات اللي تحتاج يمشوا للسي تي سكان او لا.
شكرا جزيلا هشام. معليش نطلب منكم كلكم زملاء الاعزاء يكون الاختصار، لان كميه الاسئله شيء يعني ما شاء الله كبير جدا، والوقت بدا يداهمنا، يعني باقي لنا بس 45 دقيقه والاسئله كثيره. اذا ممكن نوجه السؤال اللي جاي للدكتور سراج. في سؤال للدكتور سراج بحكم انه من اي سي يو. واحد من زملائنا يسال عن طريق الشات يقول I read an article about patients who tend to get worse with ARDS. وحسب his reading he says that this was related to three risk factors: high liver enzymes, especially ALT, myalgia, and elevated hemoglobin. فيسأل what is your opinion in this situation? Are you aware of these being specific risk factors for ARDS or deterioration, Siraj?
Sahit, I am not aware of them being specific risk factors in association. That's something that's going to have to be studied, but I will answer your question simply. What difference does it make? I think any of these patients can progress to develop ARDS, and I don't think you're going to, if you're looking for the silver bullet that's going to tell you what's going to happen, welcome to medicine, right? That's not going to happen, especially when these cases, as Hisham just said, being a pandemic. So basically, I have been surprised to see patients progress to ARDS that I thought would not. And I have been surprised to see patients not develop ARDS that I thought actually would. So there's no specific correlation or association that I can say this person is going to be bad versus not, to be honest. I will say this. Generally speaking, the previous data says that patients that are diabetic, they generally have less ARDS development. And the reason being is that hyperglycemia and glucose is actually toxic to the neutrophil that is very specific for the development of ARDS. Anecdotally, that doesn't really fit here, right? Because we're saying that the diabetics and the patients that have multiple comorbidities are developing more ARDS. So as far as I'm concerned, anybody's at risk. Who's at risk? How am I going to figure it out? You're increasing FiO2 requirements. Just be careful when it comes to day 8. They fall off a cliff and they go bad very fast.
Thank you very much. There are a couple of questions related to diagnostics. I'll answer very quickly, so just to serve the time. More than one person is asking about a late PCR and whether that indicates continuing infectiousness. The answer is no one knows. Most likely is that if you've got two negatives and a positive after that, there are two possible explanations. The first is that one of the two negatives was a false negative, and the other one is that whatever you're detecting now is non-detectable virus. So no one knows if PCR after clearance indicates infectiousness. The likelihood is that it's not. There's more than one question asking about the role of serology in acute infection, and the answer is it has no role. We've got more than one study now that show that IgM appears after 7 days, so that would be too late. But it may have a role later on in detecting, doing seroprevalence studies. Okay, so there's another important question. I know we've addressed it, but if it's nice if Ala or Hala or Dr. Hisham can just briefly, a specific question that says, when do we need to admit the patient? When do we need to admit the patient?
Ala, can you answer that question?
Yes, well, it's a challenging question. Yeah. So the majority of cases doesn't need admission. وطبعا للأسف مش هذا الفكرة اللي موجودة في ليبيا. معتقدين أن كل COVID-19 case needs to be admitted, which is completely wrong. Majority of cases can be managed at home with special isolation circumstances. لازم تكون الروم well ventilated. If there is لو كان في facilities إنه يكون عنده separated toilet, it's gonna be okay, or he will use the toilet, the last one, and to clean it. This is in the mild cases, mild symptomatic cases, even with cough and fever. If the patient deteriorated, we can just, with the clinical judgment, like CARB 65, or the patient is seriously ill and needs to be admitted, he has to receive the management, such as aided oxygen and supportive management with good hydration and etc. If the patient improved, that's okay. He needs to be isolated in the hospital with specific isolation room, and if he's not improved, he needs to be admitted to the intensive care unit. And it's according, as Dr. Siraj said, if he has multiple comorbidities, how to be managed. Hopefully this has answered the question.
Thank you very much.
بس علي, بس to add something, أعتقد إن الادميشن حتى هو is going to be varied according to the situation you have. Yes. If you are still in a situation where you don't have many patients, you still can maybe gonna accept more than when you have too many sicky patients around you. This is another options. People طبعا زي ما قلت لك الكرايتيريا can be different. People that use the risk factors, people have used the O2 saturation as well in terms of admissions. لكن as I said, I think Ala what's mentioned is fine. بس احنا what are the زي ما قلنا challenging في ليبيا الآن. What I'm saying دولز ليبيا باش يكون الجماعة احنا يكونوا معنا on board. challenging في ليبيا. isolation facilities is very limited as yet. يعني احنا الآن لو يكثروا الحالات ما عندناش where we're gonna get them into it. And I think now we have Mitiga, we have مستشفى العيون اللي هم supposedly they're gonna admit into it. لكن I'm hearing up to yesterday there are still some difficulties. There is still some difficulties, a connection between زاوية الدهماني and those two places. يعني patient he might end up في زاوية الدهماني, وزاوية الدهماني can admit the patients of course in زاوية الدهماني. لكن if he wants to isolate them in other places, still there is no sort of arrangement which is supposed to be. المستشفى المركزي.
بس لو نعطي نصيحة توا الأفضل للجميع إذا تمكنوا طبيا no admission أفضل. admission بس if there's very clear likely benefit complications and difficulties طبعا challenges موجودة. سؤال ليك, شكرا لكم الاثنين. سؤال ليك سراج مرة ثانية specific for ICU. A colleague is asking what is the role of early bedside tracheostomy to decrease dead space? No. That's
we could talk about that for an hour. No, because you're not going to be able to ventilate them with high PEEPs, and there's no dead space here. So you're talking about PEEP problems. So long story short, no. I don't even think you're going to be able to get a surgeon to do it for you. So no.
Good. But that's a very straight answer. Thank you. Hisham Baratania, you spoke about some of the infection control precautions with transmissions. There's a specific question. Someone is asking, is the N95 mask superior to the surgical mask for medical staff? ومعلش لأن في question also related, so I'm going to link both together. The other question is someone is asking, what is the risk? هو السؤال يقول شن نسبة انتقال الفيروس من المريض إلى الدكتور. In other words, شنو هو الريسك إن transmission من المريض للدكتور؟ شو الفرق في البروتكشن ما بين FFP mask or N95 mask versus surgical mask?
Okay. طبعا الريسك متاعك بين المريض والدكتور يعتمد على how much the doctor in contact with the مريض as well. Or how, this is important. If it's just he's going to receiving in a triage room and he's going to perhaps taking some blood test, maybe the risk is very minimal. Like you meet our patients somewhere with the COVID and you don't know about it. أعتقد at this time, if you are a doctor at that situation, as I said, in a triage room with taking history and taking blood from him, يعني a surgical mask with the gloves because you're taking blood, with the gown. In fact, even apron is fine. I mean, in the UK they use an apron, but let's say gown, that is enough. But if you are dealing with the patients, like for example, a situation with the Siraj where he's going to end up maybe going to bronchoscope the patient, is going to intubate him at any time. So this is the time where might be the risk is higher than the other person. At this situation, you might need more protection. And here where we're going to talk about N95. But the problem with the N95, doctors are using it, but they don't test it whether it's going to be fit enough and it's going to really protect them. And even the data which is coming from China and Italy, which they said there are many healthcare workers get infected, but no one told us they're infected because they are wearing surgical masks or they are wearing N95. So that is another question. They are infected, but they have their as well. They have their protection, but no one mentioned which is they make them at risk. For me, I think يعني في ليبيا بالذات الآن السيتويشن في ليبيا بالنسبة للماسكس it's not really available widely. There are difficulties. لو إن إحنا استخدمنا ال N95 in improper way مش هنلقوهم في proper ways. فأعتقد, as I said, there is a way where the surgical mask is high, and there is a place where the N95. I will be happy to use surgical mask for me, as I said, in a daily work, provided I'm not going to take work like Siraj. Maybe Siraj work, he needs extra protection. So not every doctor has to be وايت. المشكله ان الدكاتره بيشوفوا انه لازم يلبس اللبسه الصينيه هذه اللي هي من فوق للوطه وخش اللي هي ما تقدرش تقعد فيها يعني it's gonna be difficult time. هذه ما اظنش تحتاجها لدكاتره احنا daily activities. البيبل particular people who they are in contact with them maybe they need extra protection.
شكرا لكم. There's a question about, more than one question about effectiveness of passive immunity. So I'll take this one very quickly. Again, there's no evidence at present that convalescent serum is useful. There's one study that included only 5 patients, a case series. The patients seem to have improved, but there was no comparator arm. So we don't know if it works or not. And there's a lot of interest. But at the moment, it's not a standard treatment. It's still a very, very early investigation treatment. Again, ممكن زملائنا اللي في ممكن حالة وآية. في سؤال that says specifically, this is a person who describes that their regular outpatient work includes seeing patients with COPD and type 2 respiratory failure. It also includes patients who may need nebulizers and non-invasive ventilations, including NIV and CPAP. But the question is, should they be wearing full PPE for any aerosol generating procedures when they're looking after these patients?
I'm assuming that question is for me. So I would not even put patients on. I'm sorry. I'm just going to say because it's the positive pressure and the limit. I would not put these patients on CPAP or BiPAP. I would not do that, period. If you're at the point where you're thinking of BiPAP or CPAP, no, intubate them. And when you're intubating them, for the record, it's a closed circuit. So, and don't do frequent suctioning. Don't deflate the cuff and suction around his oropharynx, because every time you do that, you're exposing them. So arguably speaking, and Hisham and the ID folks can probably comment on this, if you have a TB patient on a vent, he's isolated. There's no aerosolization, right? Basically, you're keeping him inside. The same thing with these COVID patients. Don't just be bronching them and opening the circuit and closing it every time just because you want to do something a little simple. Keep him closed, limit your contact with him, and BiPAP and CPAP universally by every society of critical care in the world so far, everybody has recommended against it. So don't open that door up for yourself, is my opinion.
Yeah, I think that's very, very clear advice. But also the question, I think, relates to people who come for outpatient treatment. This is not patients with suspected COVID. So just to answer that, I think you need to do whatever you're doing normally as your infection control precautions. If there was any question that such a person might have COVID or SARS-CoV-2, then you would definitely need to wear full PPEs, because these are high risk aerosol generating procedures, just as Dr. Hisham has just described a minute ago. A few questions related to pregnancy, children, neonates, vertical transmission. Who wants to take those questions? So the first question is someone, Dr. Ahmed Rami, plastic surgeon. He wants to ask specifically about pregnancy being a risk factor for severity. He also has a question about risk of vertical transmission and whether there are any treatment options for pregnant women. Hisham, do you want to take this one?
Yeah, well, Children. Children, as I said, children. We are worried about the children from one thing. لأن most of the evidence the children they are asymptomatic, but they might act as a reservoir for the infection, spreading the infection. لأنهم أولاً زي ما قلت لك children they're not looking after themselves in a way of hand hygiene and everything. بس لكن هم they might spread the infection around, وخاصة مع old age when you cuddle them, when you do them in the families, هذا you might get the infection. Especially as I said, most of them they are asymptomatic. مع إن إحنا we start seeing some can be serious and some has passed away, لكن there are still a few small number compared to the adult. But this is where the children our concern about maybe they are working as a spread. Pregnancy. The pregnancy, I think maybe there is no much of evidence of vertical transmission. Maybe it happened in one or two in the evidence, but I don't think there is as a risk, because even in China, they give them a chance of vaginal delivery. COVID positive pregnant, they have a vaginal deliveries, and there is no evidence of the vertical transmission. But as I said, there are some reported, but there are not many. So it's not a major issue. So this is a pregnancy
right.
and the children.
Yeah, you're right. The risk is very small. There were a couple of Chinese studies. One detected IgM in newborns, and that would obviously not be from the mother, and one that detected virus. There's no specific treatment for anyone, let alone women in pregnancy, but that's perhaps a question that I can direct at Hala. Hala, there's a question مفضلك here that says, what is the role of antibiotics بخصوص المضادات الحيوية؟ specific question يقول بخصوص المضادات الحيوية في حال كان التواصل مع المريض فقط عن طريق الهاتف. كيف يمكن التمييز بين المريض الذي قد يحتاج علاج بالمضادات الحيوية بسبب التهاب بكتيري بالإضافة للفيروس، وكيف يمكن الجزم؟ هذا if you're hearing me, if you can unmute yourself and take this question. Okay, do you want Ala to try?
Okay, to differentiate between bacterial and viral pneumonia, I think...
Over the phone, that's the question.
Over the phone.
Over the phone. Someone's consulting over the phone. That's what they're trying to find. Are there any tricks? Is there anything that you could look for that can help you advise over the phone?
I think the cornerstone here is the history. If there is any contact with the COVID-19 confirmed case or the family member with the same illness, but I think لو كان مش على التليفون كنت حنبعت له بروكالسيتونين.
Okay. لكن لو كان على التليفون بتحاولي تسمعي الأعراض، لو مش متأكدة ممكن تعطيه انتيبيوتكس وخلاص. يعني ممكن يكون أسلمنا من يجي المستشفى، يعني إذا كان حتتكلم بطريقة واقعية يعني.
بالضبط. وفي نفس الوقت to convince him about isolation لحد لما نشوف next upcoming days يعني شن بتدير في البيشنت يعني.
Okay. عندي سؤال. شكرا جزيلا لك دكتورة. سراج, I'll give you now the word وحطيك
Yeah, just real quick because it was an important question. So H1N1 when it happened, it was specifically unique to affecting pregnant women, and they were very vulnerable. I happened to be in fellowship when that happened. We had patients that were pregnant and they were prone. So you can actually do that. So long story short, you treat a pregnant critical care patient as if she's not pregnant. You do whatever you feel is clinically appropriate. Don't make that be an obstacle. And so far, we have not uniquely seen pregnant females with COVID. I'm not saying there's data about that, but it just hasn't cleared itself up. But when you get a pregnant patient, nobody likes those patients. Everybody in medicine is afraid of those patients. But the rule is you treat a pregnant patient that is critically ill as if she's not pregnant.
We have one who is a pregnant.
There was an association obviously between severe pneumonia and viral pneumonia and pregnancy generally, but so far the data from China in particular is not showing them to have particularly bad outcomes. Siraj, if you can very briefly, because the questions, mashallah, are so many. Direct question about TPN instead of feeding in ICU.
No.
And the second question is about fluid management in relation to AKI, again in ICU.
I do not like TPN. Feed them nutritionally. feed their gut, at least trophic tube feeds. You don't have to get the goal. The new recommendation, you can feed a person that's paralyzed because those are muscarinic receptors. They are not the same receptors that paralyze your diaphragm. The gut actually moves, and you fill the gut and you prevent translocation. Feeding is very, very, very good. TPN is bad. So I would feed them unless they're not tolerating, okay? And there's no real residual volume left that makes you stop feeding. Some people say 250. That is actually not true. Up to 500, if you want to argue, I would let the tube feeding go. He needs nutrition. Otherwise, he's not going to be able to get this. TPN, I don't like TPN on anybody that has a gut that works. If your gut works, don't give TPN. TPN is bad. The last thing you want is these patients to get a fungal infection and have problems with the TPN. What was the second question, Adi?
Very briefly, fluid management. I know it's a big topic. So
keep them negative. Keep that. What you want to use normal saline. You want to use LR. Keep them negative. And he's going to get some antibiotics. He's going to get some drips. Calculate totally. Keep him as negative as much as possible. Give him Lasix until his creatinine starts to go up.
Thank you very much.
Keep him negative. Keep him negative.
Okay. We've got Dr. Tariq Najib, who's interacting with us through Zoom. Dr. Najib, Dr. Tariq Najib, you now have تفضل دكتور. You can ask your question live بالعربي بالانجليزي زي ما تحب. اهلا وسهلا بك. تفضل دكتور. وعليك السلام. تفضل.
شكرا جزيلا على هذا البانل. الحقيقه very interactive. We all learned a lot from you guys. So سلامي للدكتور سراج مشار.
خير طارق.
شنو امور شحالك؟ الله يبارك فيك.
الحمد لله.
اسمي طارق نقاب. أنا critical care pulmonary critical care. So my only argument here with you guys is there was a lot of data coming from China and Italy about early intubation and how bad these guys are doing, and then they really deteriorate really fast. So there was a lot of data coming from overseas and actually from Washington about how beneficial for us to put these patients on a machine. One of the benefits, as Dr. Oshar said, because it's a negative circuit, right? So you have a patient on the machine, you're protecting your healthcare providers, and you're kind of preventing all the aerosolization of the virus. However, because of the lack of these many ventilators, I mean, even here, we're not having as much ventilators as we want to intubate all these patients. And from the East Coast, apparently there was a little bit of shift about not to early intubate these patients and do a trial of positive pressure ventilation or high flow. And the Society of Critical Care Medicine actually came up a couple weeks ago with these recommendations. In Libya, I know it's really difficult to comply with all these recommendations. So what probably need to think about is what are the feasible things to do in a country where probably...
Dr. Tariq, I'm terribly sorry. I know this is extremely rude, but can you make it very brief, please? Because there are so many questions and there is only 20 minutes left.
Yeah, so the question to Siraj is, can we give an excuse to people to do a trial of BiPAP or CPAP given we don't have these much ventilators, so a lot of people will die just because there's no ventilator.
Okay, to make it quick, I think there are going to be a lot of people that die if this really hits the right place at the right time, unfortunately. So your question is going to involve resource allocation. From my opinion, and to make it quick, I think by putting these people on BiPAP, you are exposing healthcare providers that should be available to treat other sick patients. So if you're at the point where you want to do BiPAP, I think you're opening up a slippery slope. I know the data probably shifted a little bit based on resources. I think some places we're even having talks about ethical decision-making when it comes to limited resources and who gets to use that versus not. This is not an easy topic. And at the end of the day, I would do what the panel of clinicians that are involved in taking care of these patients agrees to. This is not a unilateral decision. I think it's going to involve a lot of people. And this decision goes higher than just the doctor treating in a room, because how society is going to see not offering treatment to somebody is going to be very complicated. So your point is fairly taken. I don't really have a great answer for you. Personally, I would not BiPAP that, because I think you're going to expose the healthcare providers and you're opening up a slippery slope. That's my personal opinion.
Thank you very much, Siraj. هشام, if I could ask you two questions. واحد يسأل قال إذا سقط الرذاذ على الغذاء فهل هو ناقل؟ وفيها different question that asks, can you just autoclave the N95 masks and reuse them again? تفضل.
الرذاذ طاح على الغداء قدامه يعني الماكله يعني.
ايه
يعزق
السؤال.
وما فيش غير وما فيش غير هالماكله يعني هو بيخش ياكلها مازال هذه اللي فوق الرذاذ. و very difficult question. إذا كان هو شاف الرذاذ قدامه وما زال he's gonna eat it, it's gonna be it's very challenging, I think.
بالذات كانوا بزين يا هشام.
Yeah, this is I think is a very tricky question. لكن ما دام في رذاذ يعتمد على بس نقول احنا يعتمد على الحراره. Maybe لو كان very hot things والرذاذ قعد فتره احنا نعرفوا ان الكورونا it's not tolerating temperature above 60. This is what the evidence is. فإذا كان الفيروس stayed in the زي ما يقول البنزين السخون for more than 60, I think it's going to have a difficult challenge. But I would لو كان طايح عليه فاكهة وحاجة قدامه رذاذ ما أعتقدش إنه هو الأسلم إنه هو يأكلها يعني، أو إنه هو يمشي إذا كان هو بيضطر إنه يأكلها يمشي يغسلها غسلة كويسة وينظفها، ممكن بعدين إذا كان هو لازم يأكلها يأكلها. أما بالسؤال الثاني اللي هي حكاية
الأوتوكليفنج
والله this is أعتقد UK just raised it recently. They said إن you shouldn't but لو كان ما عاش فيه resources أو ما عاش فيه limited things ما عاش عندك يعني other chances. People are arguing about autoclaving 95 لكن the question how valid قال لك إذا كان هذه في حالة إن لا تملك أي ماسك خلاص وما عاش عندك resources، لكن هم طبعا it's not recommended.
They would not stand autoclave anyway. Maybe they mean irradiation يعني.
irradiation kind يعني مش autoclave كtemperature autoclave يعني.
في سؤال يسأل عن how long the virus lasts on clothes, but I think this was not covered by the study that you nicely presented earlier. فيه سؤال أكثر من مرة يسأل رغم أنكم يعني I know أنكم you tried لا وهشام وسراج everyone. لكن the question is returning فلذلك I want someone just to say it clearly بس الناس ترتاح. Can you really manage people at home? Or people want to have some practical. لا غطت جزء من الكلام هذا in her presentation. موضوع self isolation at home إذا ممكن دكتورة علاء، وهل أنت فعلا can you manage people with confirmed virus disease at home or not؟ دكتورة علاء تسمع فيها؟
آسفة دكتور علي كان يقطع الخط.
اوكي سو في سؤال اذا ممكن تاخذيه. السؤال مرة ثانية زملاء كثير يسألوا هل فعلا تقدر can you manage patients عندهم كورونا suspected ولا confirmed at home؟ ولو حيمشوا هوم ايش هي الخطوات والنصائح العملية للعزل في البيت؟
اوكي
ولمدة كم؟ This is also a question.
اوكي الهوم ايزوليشن او السيلف ايزوليشن يعتبر هذا المين ستاي اوف مانجمنت especially in UK. فمزبوط طبعا الهوم ايزوليشن يعتبر حاجه كورنر ستون، بالذات زي ما قال الدكتور هشام لو كان زاد النمبرز وما فيش فاسيلتيز اساسا ولا كاباسيتيز للادمشن. هذه أول حاجة. طبعاً المين ثينج في السيلف ايزوليشن أو الهوم ايزوليشن هي أن البيشنت يكون ويل educated، يعني isolated بمعنى isolated، مش زي عنا إحنا الليبيين والله أنا isolated ما ندير في شيء نقرأ في القرآن هدرز على الصغار فما تجيش. فايزوليتد يعني ايزوليتد بروحها. هذه أول حاجة. الانفايرمنت بتاع الايزوليشن مهمة جداً. environment بتاع الايزوليشن regarding ان هي تكون روم بروحها well ventilated. لازم البيشنت boosting his immunity by healthy food, by vitamins, by good hydration, and also as we said about toilet. Regarding for how long طبعا لو كان البيشنت suspected او لو كان confirmed COVID-19 احنا نعرفوا ان قلنا duration of illness could be up to 6 weeks، لكن هذا لو كان البيشنت stable والsymptoms بتاعه improving و he's doing very well 14 days should be fine.
Okay.
Hope this answered the question.
شكرا جزيلا. You have back to our intensivist.
Yes.
If you can do it in 1 minute, I don't know how long it will take. Someone is asking, what is the idea behind proning? What is the physiology? Why do you want to prone people?
So anatomically speaking, the posterior part of the lung is more round, and it has a better VQ proportionality. The anterior part of the lung is narrow and tight. So when you have exudate in the lung, it naturally falls down because of gravity. So everything in the sediment is going to sit down on the posterior parts of the lung. And that remaining lung anteriorly is what we call the baby lung. It's enough for a baby, it's not enough for an adult. And you have the heart in the anterior mediastinal structures pushing on the actual lung. Everything is a matter of volume and pressure. كيف القربة هي بس بتاخذ هواء ما تبيش تاخذ مية بس انت حاط مع الهواء هذه المية واسعة. So you want to improve the ventilation and the perfusion matching. When you flip a person on his actual face, you're going to have most of the lung in the posterior zones available because the sediment is going to fall anteriorly. And when it falls anteriorly, the anterior part of the lung is less compliant and doesn't have as good VQ matching overall. So why don't I use that dead space, have the sediment fall into it, preserve the posterior elements of the lung, and take away all of the anterior mediastinum and put it back? Long story short, you have to wait for the patient to get better by himself. All I'm doing is supporting him until that happens. And the support is, I want to make sure that I oxygenate him well, and I don't keep his lungs very inflated to a bad point as his body gets better in association with everything else. So proning makes you able to oxygenate the patient with good volumes and pressure that are not going to damage his lung on the long run until, inshallah, he gets better. It's not magic. Basically, we're just sitting in the background trying to keep the physiology as even as possible until he gets better, inshallah.
شكرا جزيلا لكم. Maybe we could talk about it at the end as well. Like, more than one person is asking, how can we be in touch if we have specific questions about specific meeting again on fortnightly basis and every 2 weeks if we can. And if any of you is willing to be contacted.
علي الصوت متاعك يقطع.
Okay. تسمع فيها تو أحسن؟
يا carry on.
اوكي سو في اكثر من شخص يسال عن طريقه التواصل مرضى بعينهم، واظن السؤال يوحي بان اغلبهم منكم الاي سي يو ويحتاجوا ممكن يتكلموا مع سراج. ف
I am available. You guys can have my Viber number. The time difference is going to be a little bit challenging. I am more than happy if you guys want to dedicate a certain time where somebody can just run the cases by me. You can just send me a text message. I can make my number available for you guys. I am more than happy to help as much as I can and help you at least think through this.
Jazakallah kul khair, Siraj. I'm sure they will appreciate it. There's more than one person making that request. Dr. Hala, I don't know if you're still online with us or not. If you are, can you unmute yourself?
في الدكتورة هدى رجبي عليه raising her hand.
Okay.
She needs to unmute. Yeah.
Yeah, she can talk now.
دكتورة هدى رجب، أهلا وسهلا بك. تفضلي دكتورة، we can hear you. تفضلي.
السلام عليكم.
عليكم السلام.
اوكي باختصار اولا شكرا لكم دكاتره. السؤال بس بالنسبه للهيلث وركر وانا when can I consider myself a carrier؟ يعني زي قال إيري في جواب لسؤال سابق دكتور هشام قال بالنسبه لي surgical mask is enough, gown is enough, but can I consider myself a care for a family or other when I go home back? If
Yes,
I already examined or
question.
if I've already seen a COVID patient.
It's a very good question.
Doctor, I'm not ICU doctor, by the way.
I'm just going to mute you now. شكرا جزيلا لك لسؤالك. So the question is now
about self-isolation. Should I?
Yes, the question is clear. So Hisham, do you want to take this question? So the question is, someone is working with COVID patients.
Okay.
Can I just go home, or do I need to do something different?
Well, we are all working with the COVID patients.
Uh-huh.
Okay, and we are see them, and we have many start around us. I mean, if you take our experience here now, I think we have it around us all the time. If you are, as I said, if you are gonna come and deal with the patients, is just a normal activity, seeing the patients, maybe just a chat with him. You're not gonna do much, and the patient's on his bed, perhaps he's wearing his mask, and you are wearing a surgical mask plus apron or a gown with the gloves. This is enough, and I don't think you need to do anything more than this. Perhaps you of course you need to get rid of those things in the right way. But if you are dealing with the patients, yes, washing hands, that's important and vital. But if you are dealing with someone who are, you're more in contact with the patients, perhaps where there are more aerosols coming from him and makes you further, interference with the patient, like in an ICU, of course you need to have a PPE, further protections. The further protection, if we talk about Libya, as I said, or, and I mean, not Libya, now in any places, even here, N95, and you need to test it, and important to test the N95 with the gown as well, with the gloves. What about the covering hair, the what you call the cover hair? No much of evidence of that, whether it makes any difference, but if it's available, is fine. And as I said, washing hand and proper get rid of it. This stuff is important. I think you need to watch Dr. Ali's a video, which is in the webpage as well, in the Alistishari Facebook page. And it's very valuable and very important for us how to use these things. But I don't think we need to do anything further. Perhaps you need to monitor your symptom as well if anything goes wrong. But you should have your normal life.
Yes. Now, in some countries, and that depends زي ما قلت هشام على الإمكانيات المحلية. في بعض الدول إذا فيه دكتور يشتغل مع حالات معروفة وموثقة ينصحوهم إن هم ما يكون عندهم سكن مختلف. لكن في الدول هذه الأنظمة وفرت لهم سكن. فالإنسان لازم يتعامل بالوضع اللي هو فيه بالظروف اللي هو فيها. إذا أنا مثلا عارف نفسي إني عايش مع شخص كبير في السن عنده أمراض مزمنة وأنا نشتغل في خط أمامي، ناخذ الاحتياطات اللي وصفها الدكتور هشام ووصفها زملائنا كلها، وممكن نحتاط الضعف أكثر حتى لما نرجع البيت ناخذ احتياطات أزيد شوية. فهذا مهم جدا. لكن هذا ما يمنعش طبعا احنا نؤدي واجبنا ونستمر في تقديم خدماتنا بالاحتياطات المطلوبة. في سؤال يا ريت لو دكتورة آلاء ودكتورة هالة، تفضل صراحة.
قبل علي ممكن ناخذ منك الميكروفون شوي لو سمحت؟
تفضل.
في سؤال للدكتور سراج خاصة. if the patient is arrested, can the doctor do CPR, and what's the precaution should be taken?
Very good question. I read that question as well. This is just give me 90 seconds. When you do CPR, you basically want to save and preserve the patient. You have to keep in mind, guys, if this person is arresting, he's already on drips. First of all, if we arrest while he's prone, good luck. I have never seen a patient that's prone that gets CPR that lives, because you're going to have to flip him back. By the time you flip him back, good luck with that. Second thing, if he's already on drips, you're already basically chemically coding this patient. If he's on norepinephrine, epinephrine, vasopressin, fluids, vent, PEEP of 18, PEEP of 20, you're doing whatever medicine has to offer. So the misconcept of CPR is that it's only epiatropine and some antiarrhythmic drugs. The reality is that you want to save the brain and you want to save the patient. So your first question should be, is the benefit outweighing the risk? Are you going to be able to get this patient to a point where he's going to do better? If he's already that sick on that many things, once the CPR is initiated, it's your clinical duty as a physician to decide if benefit outweighs the risk. Nobody can answer the question for you. Do I do CPR on him for 5 minutes, for 20 minutes? Do I give him 3 rounds of drugs? Do I give him 5 rounds of drugs? I don't know how to answer that question for you. What I would do is, if the benefit does not outweigh the risk, if the patient is not going to do well, it's your clinical responsibility to no longer further torture the patient and break his ribs and bring him back to a situation where he's not going to do well. It's your responsibility to say, this is the end, okay? Now, I know that the philosophy here gets complicated and tricky, but if you have limited resources and you have limited everything, why would you waste them on a procedure that is not going to get the patient to a good point? We start thinking of numbers and we stop thinking about the patient himself. So this gets tricky, right? I'm not going to be able to answer you and say, don't do CPR on a patient, right? Because there are a lot of pathways to this discussion. But as a physician, do your job the right way, in a genuine way, in an honest way. If you cannot help him, all I can say is La ilaha illallah. You've already done everything you can. You've intubated him. You put a line in him. You put him on drips. You've proned him. You've tried to fix everything about him, right? So if the harm is more, it's time to stop. And that's an opinion. Now, I have to be black and white. This question has to be answered black and white, right? There's no data out there that says do CPR for 10 minutes or 30 minutes or an hour. Or there's no such data.
Thank you. في سؤال في الآخر عن sensitivity to diagnose COVID. Should you use serum or nasopharyngeal swabs? The answer is you don't use blood or serum at all to diagnose COVID. You only use upper respiratory or lower respiratory samples for diagnostic work. You can detect the virus elsewhere, as Dr. Hisham said at the beginning, but that's not for diagnostic purposes. سؤال ممكن دكتور هشام. Someone is asking, if you've been exposed, how long before you become infectious? Yani, you pass the point that you've become infected and now you're being infectious. How long?
How long you're gonna you've been exposed? How long?
Exposed? How long after that do you become infectious? If you have another question, you might take it at the same time. And then how long do you remain infectious?
Right. Okay. Well, that's as well. It's a very difficult question to say, but I think you will have a safe 24, 48 hours after the virus you've been exposed to, before you might become infectious. People say the 5 days is maybe the 5 days is an incubation period, but it can be shorter as 2 days, and it can be delayed up to 2 weeks. But I think 5-6 days after exposure, this is the time where you're gonna be infection definitely happen. Now, how much before the symptoms start? Maybe 2 days before that, you can spread the infection. How long are you going to spread it for? You could spread it up to 2 weeks. Perhaps now people say you might be after up to 3 weeks, and depends on the severity. So it just depends on the patient. But I think from the time you get the symptoms, I think, or 1 day before that, up to 6-7 days after that, this is where the highly infectivity period is going to be high.
Do you recommend they wear masks until that period?
Well, this is what they say for the doctors in the UK. What they try to say, it's very difficult to every doctor exposed, they're gonna send them home to isolate it for 2 weeks. But what they found, they recommend, if you are exposed and you think you're not really protect yourself, perhaps you need to monitor your symptoms and you keep the mask all the time, because that will protect the others. And then you monitor symptoms every day. You still can't come to the hospital. You have to protect all the time. You shouldn't take that mask whatsoever. And then you have to monitor your temperature or whatever. Once you have the symptoms, then off you go.
في باقي 5 دقائق. صلاح تبي تاخذ السؤالين الأخيرين؟
أعطي رقم الفايبر متاعه لو دكتور علي بتقدمه للزملاء والأطباء.
أنا كنت حنكتبه.
So you can give my number individually. Please don't put my number on Facebook, okay? But for anybody in this panel, yes, they can have my number and they can share it among themselves. مرحبتين.
Yeah.
Anything I can help with. Yes.
شو رأيكم نخلوه عند الدكتور هشام وهو عنده كونتاكت مع ال.
Okay.
That's fine by me. I mean, I wouldn't even. Yes.
Yeah.
Okay.
I have, one day once I will share with them.
That's fine. That's fine. And they can share among themselves.
Yeah. There's 2 questions. One is Sahel. COVID, is it bloodborne or not? It's been detected in blood rarely, but no one knows yet. If someone is donating blood, they'll probably be tested, especially if they had recent symptoms. but that's not a question that anyone knows the answer to yet. I think a point that you, Siraj, raised during your slides, and there are one or two people who are commenting and they want to visit it again. I know it's a sensitive area, but it's about the concept of ceiling of care. And how do you decide what you would offer which patients? Or there is more than one comment in the chat saying that we need to be sensitive about our local culture and our expectations. I don't know if you have any advice for people.
I do. I mean, I've looked in this area. الموضوع هذا حساس شوية, but I don't think it's our responsibility to shy away from it. Okay. So what I would say is this: you integra, and you get involved and you treat patients, right? Even in America, I see patients from multiple cultures, from far. There are multiple beliefs and multiple interests. You approach these cases always the same way. The patient's belief is the patient's belief, and I understand. Okay, I get patients from Bangladesh, ومن Pakistani Muslimin. The concept here is hard. You have to answer these questions with honesty. You be genuine. And you share with them the reality of the situation. We've never been involved in a pandemic before. We have never been in a situation where you have one ventilator and you have to use it on, and you have two patients. We're even having more problems, not just the ventilator. The medicine that you need to keep the patients on a ventilator. We're having problem with sedative drips. Don't expect yourself that the ventilator is going to be enough. Are you going to put everybody on dialysis? Are you going to offer everybody 3-4 pressors? The question of your limited resources always comes up. Use your best ability. I cannot take a person off a vent without them understanding and realizing where this is. So again, I totally respect the culture. I deal with it. And to share a personal story, when people that are relatives, when they call me and they have terminal cancers, I tell them there's nothing that you can actually do. ازعلوا مني. Okay? I will share it. ازعلوا مني. كيف they went and they did what they did, and I'm better off saying the truth than I am having him go and do something else. So when you're faced with that scenario, you need proper support and you need proper backup in the society that's around you to be able to address that. فالوضع واعر شوية, ما عنديش حل له أنا حاليا في ليبيا, ولكن حتى هنا راهو واعر, حتى في الغرب راهو واعر. الموضوع هذا يبي كوميتي مؤلفه من ناس ما همش اطباء، ناس عندهم خلفيه دينيه، ناس عندهم خلفيه اجتماعيه، ناس عندهم خلفيه من كل تركينا، بحيث ان كل every angle is addressed. You want to make sure that you cross your T's and you dot your I's وتاخذ بالك من الموضوع هذا، لان الموضوع حساس جدا. لان all of a sudden when you talk about life and death يتبحر الموضوع جدا. فانت simply speaking, if you don't have a pulse, you're dead. If your blood pressure is 30/20 and you're on 3-4 pressors, I'm not going to be able to improve that. So at the end of the day, واحد زائد واحد يساوي 2, and so forth. There's some of medicine that's above my pay grade, right? A lot of, not some, a lot of medicine is above any of our pay grades. لأنا, لهشام, لعلي, لدكتور صلاح. There comes a point where as a physician, you raise your hands and go, لا إله إلا الله, there's nothing else I can do. So just be conscious about being honest and sharing with patients what the natural progression of the disease is. And it is very hard. They start talking, all of a sudden ينسوا المedicine. Okay, when they start talking rituals وبelief وإيمان وتجد الموضوع حساس شوية. Just listen, absorb their frustration and do your best. And I would just come to a point where I would just not do other things. I would just tell them, I've done everything I can. And keep it to that. And وربك يسهل. And again, this is a topic that we can probably have a session on this, on how other cultures and societies are dealing with these scenarios. And as I'm saying, it is very complicated. I don't know what else to say, Dr. Ali. If you guys want to comment on this, I mean, everybody has his interaction with this.
I agree with you. I think everything you said is absolutely relevant. It's not an assumption that this is something that you only experience في بلدان عربية وبلدان شرقية. أنا طبعا اشتغل في قطر واشتغلت قبلها في السعودية وقبلها في UK، فجربت كل اللي حكيت عندنا. علينا أعتقد نديروه إن نوضحه للناس بحول الله وعونه شنو هو اللي الانسان يقدر يديره، والشيء اللي هو مش في يد الانسان مش في يد الانسان مهما كانت رغبتنا. نتمنى ان الناس كلها تتعافى ما تحتاجش، لكن للاسف هذا مش ممكن. للاسف ايضا الوقت انتهى دكتور صلاح، مش عارف احنا كملنا ساعتين. في شويه اسئله جت تو فورا في اللحظه هذه، حوالي 4 أو 5 اسئله، فمش عارف شو رايكم بسرعه الحضور.
5 دقائق يا دكتور علي، خذهم بسرعه، اجابات سريعه.
يلا اوكي باسرع وقت ممكن لو سمحت. عرفت اللي قال 10 دقائق 10 ثواني. واحد يسال دكتوره خلود تسال what about using nebulizers? Is it safe if people are around? Nebulizers?
You're opening the circuit. Why do you even want to do it? If they're on the vent, give them MDIs. You don't want to keep opening that circuit. For the record, nebulizers are overused in the ICU. If they're not wheezing and they're not tight and they don't have any problems, why are you doing it? People give them like it's candy. I think they're overused. So if you have to, you have to, but don't open the circuit as much as you need, too much. Because every time you open the circuit, you're losing your feet.
If it's outside in ICU, you need to have a full protection.
Yes.
Yeah. But that's an aerosol generating procedure. Yeah. The answer is after discharging a patient. Sorry, the question, yes. So the question is, after discharging a patient, how long do you advise them to self-isolate for? Hisham?
Yeah. Well, according to what we are doing, if you end up in a hospital with the symptoms, they ask them to stay 4 weeks.
Yeah. I know it differs from one country to another. In some places, they ask them to self-isolate for 1 or 2 weeks, but in some countries, it's 4 weeks. It's 4 weeks because no one really knows. So it depends what you can afford. Dr. Siraj, question directly with you. So do you support the idea of 1 mechanical ventilator for 4 or 6 patients? Maybe you saw the video that's trying to...
I do not. I do not. I have no idea how that's going to physically work. I have to see it yet. Because basically, and the reason being, every patient has a specific setting that he needs. Are you going to pick and choose the PEEP that's going to be for patient A or patient B or patient C? You can't individualize care when it comes to this. If there's anything, we have medicine and we have a flow standard curve. We have to individualize everything. So the optimal PEEP for patient A is not going to be the optimal PEEP for patient C. They're not going to have the same BMI unless you can somehow randomize the patients that they have the same weight, the same height, the same everything, the same every lab value, and do that. I don't know how that's going to work from a practical standpoint. I think somebody's just trying to become famous doing that.
Thank you. There's one last question. I think that we discussed it just before going live. That said, some report that cats may be infected with coronavirus.
I think your answer. That's you have to answer it, Ali.
You got that, Ali. That's your answer. That's your question right there.
So there is no evidence whatsoever that cats themselves or pets, home pets, are infected. There's no doubt that coronavirus has transferred from one animal to another, as Sham said at very beginning. Like, there's no evidence at all that it's cats. However, if I'm generating droplets, يعني لو أنا اللي نكح وطلع مني رداد بعدين نجي على أي حيوان جنبي مثلا صغير زي قطة مثلا، وقطة هذه تمشي لمكان ثاني، طبعا هي ممكن تنقل الرداد، فالإنسان يحتاط. ولو كان هو موجود في عزلة لأن عنده أعراض، المفروض إنه يعزل نفسه حتى عن الحيوانات الأليفة اللي ممكن تكون معاه في الحوش. جزاكم الله كل خير وشاكرين لكم مواصلتكم.
بارك الله فيكم. شكرا جميعا.
باسم الموقع الاستشاري الطب الليبي نشكر زملائنا الدكاترة سبيكرز وكذلك الأودينز على حضورهم هذه الندوة. بارك الله فيكم، كلنا استفدنا حقيقة. نتأسف إذا كان في أي حد أرسل سؤال وما قدرناش نقدمه للزملاء، لكن نوعدكم إن شاء الله في المستقبل القريب حنقوم ندوات أخرى وبعون الله، ونحتاج منكم لو سمحتوا إذا كان في عندنا موقعنا تبعتوا لنا الفيدباك على الندوة وش رأيكم فيها، وإذا كان عندكم أي أسئلة أو أي مواضيع تحبوا نتناقشوا فيها تحت مظلة الاستشاري الطبي الليبي. في أي إضافة من الأخوة الزملاء؟
شكرا جزيلا دكتور، وشكرا لكل البانل، وشكرا لكل حد كان حاضر. يعني بارك الله فيكم. Such a great honor and such a great opportunity to be with you. Thank you.
شكرا دكتور علاء.
بارك الله فيكم. طبعا لزملائي الدكاترة في ليبيا، يعني عارف الظروف صعبة، السيتويشن صعب، الترياج مش واضح، المرضى بانيكينج، الدكاترة بانيكينج، لكن يعني النصيحة البسيطة اللي بنقدمها انك لما تتعامل ان احنا نتعامل مع مرضى كل يوم. وجودك في الامرجنسي، تعامل ان كل مريض انه هو كوفيد until proof otherwise، مش الاذر واي. ما تتعامل بان كوفيد until proof otherwise. بسمبل قلت لكم surgical mask with the gloves with gown we could sort an issue for many patients. Thank you very much.
جزاك الله خير. سراج، دكتور سراج، اي اضافه؟
نورين صحيته. I'm glad to be a part of something and hopefully we can help. سلام.
بس انا في اخ هو اليوزر نيم از جالكسي تاب، اخ او اخت، وبعدين انا دخلت عليه فهو يلوم علي، فانا تو دخلتها بصوت فحيسالنا. خليني ندير لك ميوت. اهلا بك. الو.
قاعد بيوتيوب.
ايوه تفضل، اهلا وسهلا بك.
Galaxy Tab.
Galaxy Tab A.
Yeah. That's me. I'm sorry. I thought my name is should be obvious. It's Galaxy Tab. It's me. Yeah. This is Dr. Akili from Tripoli Central Hospital.
عذرنا تأخرنا عليك. تفضل. Hello.
Thank you all for sharing your knowledge and your participation. I would like to greet Dr. Hisham from here. My question is.
عرفنا بنفسك.
Hello.
عرفنا بنفسك.
I already said that I'm Dr. Akili from Tripoli Central Hospital. You didn't hear me. Yeah. Anyways, thank you for appearing and sharing your knowledge. There's no one specifically that I need to answer my question, but preferably Dr. Hisham, preferably.
Yeah.
And my question is, should we screen asymptomatic people? And I say, should we screen asymptomatic people who had contact with either suspected or confirmed COVID-19 patients other than advising for home quarantine? What is the purpose for that? If we do so, for how long? Will this vary from country to country depending on resources? This is my question.
بارك الله فيك محمد، وسلام ليكم للعائلة. طبعا محمد يعتمد على many factors. انت لو تشوف ال countries والamount of the test, it depends what is the purpose of the question. لكن خلينا نختصر السؤال هذا. احنا الان في ليبيا number of tests is very small، يعني احنا نتكلم على 300 tests وخلصنا منهم 200 وما زال ممكن 100 اذا كان ما جبناش other tests hopefully is gonna come next week. لو ان احنا بنعملوا سكريننج لهذا وحنكملون بطريقه سريعه، ونعتقد انه ممكن we save them to the patient who end up in hospital. ممكن الناس هادو نقول لهم والله طالما انك انت you're exposed واحنا انك انت ممكن تضل في البيت وتراقب تعزلهم في البيت وتراقب اللي هم الاعراض متاعهم وعلى ضوءها تتعامل معاهم وما تحتاج انك تدرهم سكرين. لكن اذا كان احنا في بلد وعندنا test and we want to test and more، لأن هذا for epidemiological reason as well as for زي ما يقولوا for a proper advice. ما فيش مانع إنك أنت you screen them. ما فيش منها مانع، لكن زي ما قلت لك تعتمد على ال circumstances. في ليبيا الآن مش لازم احنا ان نستخدم سكريننج اللي هم لناس around the patient، لان مرات نديروا بانيك اكثر من نديروا بنفيت. اعزله وقول له خليك في البيت ما عادش تطلع وخليك شويه وشوف السيمبتومز بتاعك. الا كانت وفرت عندنا الالافات اللي I heard انه هو there will be 20,000 samples coming if it's gonna happen.
ان شاء الله. دكتور علي،
شكرا جزيلا لكم، فرصه طيبه جدا.
يعني to developed countries. Sorry, can I continue, guys?
Yeah, Mohammed. Yeah, last thing. What do you want to say? Developed country. What do you want to say?
Yeah, to developed countries in Europe, USA.
Yeah.
I mean, why do they screen asymptomatic patients who had contact with COVID?
No, they don't.
I mean,
we don't.
While they are advising to stay at quarantine.
They don't. يعني زي UK they don't. مثلا احنا في قطر ممكن we do. It depends on the country what they want. But normally most of the country they don't do for asymptomatic patients.
بالنسبة لأوروبا وأمريكا they don't. they do only very highly suspected patients, those who are going to be admitted to the hospital. بالنسبة لبريطانيا, they started recently for possible positive doctor or nurse staff, they may got the disease. Otherwise, they don't screen everybody. I don't think they have the facilities to do
all of it. Yeah.
So just to make this will help answer the question. For us healthcare professionals that are in touch with these patients, you get a sheet. The sheet has symptoms: fever, cough, shortness of breath, blah, 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 blah. Every 12 hours, you check that sheet from your first exposure. If a healthcare professional starts having symptoms, they will consider getting him tested. But we are not being tested routinely, and we're potentially asymptomatic carriers being healthcare providers, correct? That's the closest example. And otherwise, no, it's not being routinely tested.
Thank you very much. شكرا جزاكم الله خير. في نقطتين بس. Everybody please go to you can send your questions. Our email is covid19@alistishari.org, covid19@alistishari.org. For any communication or questions or any ideas you want to send to us. Also, please, everybody to fill the evaluation form as soon as possible. Thank you very much. شكرا جزيلا لكم أخواتي الأعزاء، ونلتقي إن شاء الله في المستقبل القريب في محاضرة ثانية إن شاء الله. شكرا جزيلا لكم، وربي يشفي مرضانا وإن شاء الله يفكنا من هالمرض جميعا إن شاء الله يا رب العالمين. جزاكم الله خير.